So I'm going to present on placenta histopathologies associated with FGR. These are pathologies that show an underlying chronic undersupply of oxygen and nutrients to the fetus. Now, some of you may know him, some of you may not. I think most of you know him. Anyway, this is Elvis Presley. Elvis Presley is arguably the most famous FGR baby. In a paper prepared for New Zealand and Australian cardiologists by a British epidemiologist, he noted the king of rock and roll was a prime candidate for heart problems since he was in the womb, judging from the fact that Elvis had a twin when he was born, but unfortunately the twin didn't make it. And Elvis was the donor twin in a twin-to-twin transfusion syndrome. And being the donor twin, this left him vulnerable to SGA, and it left him small for gestational age. Oh, sorry, give me a second. And being small for gestational age, this left him vulnerable to many conditions, long-term and short-term. The king of rock and roll did demise to a myocardial infarction due to drug abuse, but still it is an interesting fact. As from literature, we know now that being small for gestational age leaves you vulnerable to many conditions, both short-term in the neonatal period and long-term. In the neonatal period, you're vulnerable to cardiovascular conditions, respiratory conditions, neurological conditions. Among the respiratory conditions, you have increased need for respiratory and ventilatory support. You're more vulnerable to meconium aspiration syndrome, and you find that these babies spend more time in the NICU, putting a stress on the health system. And then in the long run, you find still on the same systems, you find that these babies are more, when they grow up, they are more prone to hypertension, ischemic heart disease, stroke, and in the respiratory system, chronic respiratory insufficiency syndrome and restricted airway disease, and also cerebral palsy, learning difficulties, and dementia. Now, this is classification for the placental pathologies. I've highlighted the sections that we will touch on today. You can see here the placental vascular pathologies who look at mostly, these are the maternal vascular malperfusions, which are divided into early and late. These have already been touched on by Mr. Zanga in his presentation. So all I'll say is these are the ones that we normally encounter, as these are the most common. The majority of placentas following delivery for severe FGR are from maternal vascular malperfusion, and especially with coexistent preeclampsia, these will show maternal vascular malperfusion. These women usually have high uterine artery PIs and is associated with high BPs. Now, the more interesting cases when we move on are the fetal stromal vascular lesions. These are lesions that involve, you will see clinically normal BPs and normal Dopplers except for the umbilical artery Doppler. And this will signify fault in the fetal system. So if you see an abnormality in the umbilical artery Doppler and everything else is normal, that's where your pathology is. And then even more interesting are the placental inflammatory immune processes. These are much harder to diagnose. They will come with normal BPs, normal uterine artery Dopplers, and all you see at times is a small fetus. So moving on, looking closer at the placental vascular processes. As mentioned before, these are split into early and late. The early are those where the uterine artery abnormalities are diagnosed from the sources I used before 32 weeks of gestation, and the late ones are when the presentation is after 32 weeks of gestation. The later ones are the more milder conditions, which was also mentioned by Professor Nlau in the beginning. So I will not go too deep on it, but I would just want to mention a few things on the pathophysiological features. The Pathophysiology is initiated by failed physiologic transformation of the spiral artery branches of the uteroplacental artery. This restricts maternal blood flow into the intervillous space. This state of maternal vascular malperfusion is identified sonographically by the combination of a small placenta and bilateral abnormal uterine artery waveforms. And persistent ischemic reperfusion damages to the developing placental villi, causing the histologic feature of maternal vascular malperfusion, which include multifocal infarction and formation of syncytial knots, which Mr. Zambuko also mentioned. I'll give you an example later in the slide. And then another major disease process in maternal vascular malperfusion is chorion regression. This refers to poor early formation of the definitive placenta at the expense of the membrane. I will talk more on this one later also, as we have an example from one of our cases. And now moving on to the ones I said more interesting. These are the non-maternal vascular malperfusion placental disease. So as you could see from the classification I gave you earlier, we have the chronic villositis and the villositis of unknown etiology. And these have similar histological characteristics, but the etiology is different. The villositis of unknown etiology is more of a immune response, and the chronic villositis is more, the villositis of unknown etiology is more of an autoimmune response, while the chorionic villositis is more of an inflammatory response. So, let me just start by saying, as mentioned before, significant FGR and associated placental pathologies with non-maternal vascular placental diseases can occur with normal uterine Dopplers and normal BPs, making them hard to diagnose. Starting with chronic histocytic intervillositis, this affects up to 4.4% of all first-term trimester miscarriages and 0.6% of second and third trimester placenta pathology. Overall recurrence rates can range from anywhere from 67 to 100% without treatment. And affected pregnancies delivered after 22 weeks have a high rate of fetal growth restriction, up to 62%, and stillborn birth up to 46%. And this has been shown to improve with immunosuppressive therapy. And then moving on to the massive perivillous fibrinoid deposition. These are much rarer, an estimated incidence of 0.5%. The clinical correlates of MPFD include poor obstetrical history with losses usually in the second trimester and third trimester, intrauterine growth restriction, intrauterine fetal demise, live birth with development of neural disabilities. Although massive perivenous fibrinoid deposition is often associated with catastrophic pregnancy complications, new research and new intervention have been shown to improve outcomes. And then moving on to the villositis of unknown etiology and the chronic villositis, these remain under-recognized and underappreciated lesion by both pathologists and obstetricians. I think Dr. Zambuko also mentioned this earlier on in his slide. And adding to that, the incidence of villositis of unknown etiology in most studies ranges from 5 to 15%, the majority occurring in 10 placenta. And rightly so, most cases are associated with normal term pregnancy and normal newborns. But nevertheless, as we were here in this pathology talk, in low-grade lesions, if low-grade lesions are discounted, an association of villositis of unknown etiology. Nevertheless, if low-grade lesions are discounted, there's an association of villositis of unknown etiology with adverse perinatal outcomes, including intrauterine growth restriction and stillbirth. and the recurrence rate is 10 to 15% and are more common among high-grade cases, especially when the lesion is associated with perivenous fibrosis. And also to add, any of these diagnoses, as you see with their sometimes very high recurrence rates, this will help to inform counseling about recurrence rates and prognosis to mothers. Next slide. Sorry, I'm just having a bit of trouble with my slide. Let me move to the next one, just give me a second. All right. So now we have our first case. This is a 37-year-old female patient, gravida 5, para 2. Her risk factors were preeclampsia, diabetes, and hypertension. When we saw her, was 25 weeks plus 5, and she had the baby was below the 2nd percentile, and the uterine arteries were abnormal, and the uterine arteries were abnormal, and the umbilical arteries were abnormal, and she had high BPs. And she had to deliver at 26 weeks, and unfortunately, we had a poor outcome as the baby demised after 5 days. But from our charts here, you can see, as I was mentioning before, chorion regression for the maternal vascular malperfusion. Here you have a very round, I don't know if you can see my cursor, you have a very round placenta here. Very round, very thick placenta plates. Normally you expect your placenta to fill out the space, but this, because it's very small, it has a very small surface area, it's receiving blood, and also that blood just pools in the placenta. You find that after delivery, this placenta basically squishes and it becomes very small. Showing that there was a reduction in the surface area for exchange, what leads to the placental insufficiency. And then also here in the top right corner, this is the MCA Doppler. This is a brain sparing effect. You find early on at this gestational age, we don't expect such high flow in the diastolic phase. This is when blood is being shunted from other organs to the brain. Hence the brain sparing effect. And then here in the middle, you have the umbilical Doppler. You see here, this is our baseline. And when it goes below our baseline, this is now reverse flow. You should never have reverse flow at any point. Then our histopathology, which we will also focus on later with other cases and compare. We have an accelerated villus maturation represented by small, thin, elongated villi with increasing central nodes, Turney-Parker lesions, basically, cystovillus hypoperfusion. And this is characteristic of maternal vascular malperfusion. Then moving on to our second case, we have a 27-year-old female patient, gravida 3, para 1. She had no risk factors, and at 36 weeks, the fetus was on the 4th percentile on all parameters. You can see here from our charts on the top right. And then she delivered at 37 weeks with a birth weight of 2.3 kgs. And then on histology, she also had terminal villi with increased central noting, the Turney-Parker lesions, and widespread chorangiosis in keeping with hypoperfusion and acute chorangitis. So I also want to point to the fact that she had normal Dopplers and normal BPs. And then moving on to our third case, the 37-year-old female, gravida 3, para 2. She had no risk factors also. When she came to us, you can see we saw her 3 times, and all the readings were below the 2nd percentile. And the diagnosis was made in week 25 here at our first visit. And we managed to push the pregnancy up to the 35th week, and birth weight was 1.3 kg. And also, I would like to point to the fact here that Oh, okay, when we look now at the histology, you see increasing nodes and vascular and villus dystrophic calcification and fibrin deposition, which is characteristics of the other non-vascular lesions that we spoke of. And here, when you look at the placenta, the calcifications here showing early maturation, as we would expect these at this stage. And then now here, we look at a 28-year-old female patient. She came in with, we saw her quite a few times actually, 7 times. Her BPs were normal throughout, and her risk factors were preeclampsia and in a previous pregnancy. And you can see that the trend, it actually deteriorated. At 28 weeks, she had an expected fetal weight. There was an expected fetal weight below the second centile, and placental insufficiency was noted with normal Dopplers and normal BPs. We managed to push delivery. Sorry, I don't know why it's coming. Okay. We managed to push delivery up until 37 weeks, where she gave birth at 2 kgs. In the histopathologic findings, we found focal perivillus fibrin deposition. And then moving on now, and this is one of the lesions that is associated with non-vascular, non-maternal vascular malperfusion diseases. And then now looking at our cases to compare, you can see there's a bit of a trend, but also as mentioned before, there's a bit of discrepancy where we have different clinical features and we expect different lesions, but still we find that we get the same results from the pathologist. Like for here, an example for case 1 and case 2, where we had abnormal BPs and uterine artery Dopplers in the second column. For case 1, BPs and uterine artery Dopplers were abnormal, and we got the tinea-Parker lesions, but also in case 2, where they were where the BPs and uterine artery Dopplers were normal, and we expect features characteristic of non-vascular lesions. Yeah, you find that we found the same lesions as the vascular lesions. But when you now look at case 3 and 4, where the BPs and the uterine artery Dopplers were normal, sorry, you find that we are finding now features that are characteristic of the non-vascular lesions that we expect. Here you have your vascular and villus dystrophic calcifications and your fibrin depositions, and the focal perivillus fibrin deposition. The focal perivillus fibrin deposition is not to be confused with the massive perivillus fibrin deposition. This is a milder form of the disease, and the focal perivillus fibrin deposition is more associated with chronic villositis, the one that I said has a recurrence rate of 10 to 15%. So moving on, from our cases, from the cases that we found, we felt that we could do more because we didn't know much about what we could do for the women with non-maternal vascular malperfusion. So we decided to do a research project where we'll be comparing the placenta histopathological findings in vascular and non-vascular mediated fetal growth restriction to help find answers of how we can help these women, and also add to the already established body of research that's there, as this is still building up. And we find that, as Dr. Zambuko had mentioned before, some of these lesions have a very high recurrence rate, up to 67 to 100%, I think I mentioned, for CHI. And there is treatment for some of them. So if we're able to diagnose these conditions, then we can do something for our patient. So we're doing a research project on this, and then we'll see if this is indeed the best way to go about finding these lesions, and if not, how best we can do it. Thank you very much.